Midterm ISECON 2013.
I'm Dr. Mekha Andrews, and I'll be accompanied by Dr. George Thaliath. We will be guiding you through the events of the day. In these 2 days, we will be listening to 27 scientific sessions. I request all the speakers to kindly adhere to the time allotted.
I take immense pleasure in inviting the chairpersons for the first session. Dr. S.B. Gupta, current chairman of the Indian Society of Electrocardiology, who is the chief physician and cardiologist and head of the Department of Medicine and Cardiology at the Railway Hospital, Mumbai.
Dr. J.P. Alva, Dean and Professor of Medicine at Father Muller Medical College, Mangalore.
Dr. B.H.K. Rao, retired Professor of Medicine, Kasturba Medical College, Mangalore. Kindly take your designated seats.
I invite our first speaker, Dr. Jayaprakash S., onto the dais to speak on how to read ECGs rapidly at bedside. I request the chairpersons to introduce Dr. Jayaprakash.
Good morning to all of you. I'm pleased to start the first talk on the midterm ISECON 2013 at Mangalore, and I welcome all of you to this first session, which will be first talk, which will be delivered by Dr. Jayaprakash S., who has done his EP in fellowship from Royal Melbourne Hospital, Australia. He is a fellow of American College of Cardiology and fellow of Indian College of Cardiology. He is professor of EP unit, Department of Cardiology at Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. He is also a consultant electrophysiologist at Vikram Hospital, Bangalore. And he will be talking on how to read ECG rapidly at hospital, at bedside. And I think with the experience, we know how to read ECG rapidly, and in some cases we may have to devote more time for reading an ECG. So I'll request Dr. Jayaprakash to come over and elaborate on the subject, how to read ECG rapidly at the bedside. Dr. Jayaprakash, please.
Chairpersons, ladies and gentlemen, it's indeed a pleasure for me to be here to give this talk on how to read ECGs rapidly at bedside. Now, without wasting much time, in the next 20 minutes or so, I'll be speaking on how to quickly go through the ECGs to identify what is normal and abnormal. So if you find that the ECG is normal, you can quickly pass on. But however, you should be able to quickly pick on what is abnormal and how to identify it. Now, this is what I'm going to show it is something which has come out of my own experience of seeing ECGs. It is not given in any textbooks. Number two, I'm not going to speak on a lot of theory. So just forget it, just relax. Now let us go through this. ECG is, after all, a graphical representation of the electrical activity of the heart. So it is just a squiggle of lines which come out on the paper of how the heart works. Though it's widely available and it is not used very commonly, people can't interpret it very commonly, and sometimes they order for an ECG but they are unable to interpret it. They ask somebody else to interpret it. So the whole idea of this talk is for all of you to quickly pick up what is abnormal. Why? Because many a times when you make a wrong diagnosis, the further treatment may be inadequate, or you may give the wrong treatment. And unfortunately today, ECG is a lost art, reading ECG. It is really unfortunate. It is the only investigation which has stood the test of time for more than 100 years. It continues to be so. And for some conditions, it is mandatory that you should have an ECG, which is like arrhythmias, you can't do without an ECG. Or myocardial infarction, you should diagnose it with an ECG first. So let us go through how to diagnose, how to make a rapid diagnosis. Now, I'll make it very simplistic, though it is not so simple. Basically, though the heart is 4-chambered, electrically it is 2-chambered. So you have the atria and the ventricle as two components. So let us forget all the complex things. So it is a 2-chambered electrical activity. So out of that, when it depolarizes, you get one complex. When you repolarize, you get another complex. So totally, if you see, there are about 6 complexes, not 4. there are 6 complexes, that is PQRST. Let us be very clear. Now, since it's a graphic representation, the representation occurs on a graph paper. That graph paper is the ECG paper, which has small squares and big squares. So let us forget about the timing interval and all that, which will be taught to you by others, which you can read it in the books. Now, I'm going to take you through this. Now, since the heart is pointing leftwards, the electrical activity is towards the left lower leg, or more towards 60 degrees. The normal electrical activity is anywhere between minus 30 to 90 degrees. But most of the time, it's around 60 degrees. So it is more towards the left side. If you remember that much, that is more than enough for you to make many quick diagnoses. Now let us look at it. How do we quickly decide whether your heart rate is normal? I call it the rule of 3 or 5. Now we know big boxes. So let us look at it and see how many big boxes are there. If it is more than 3 big boxes, and if it is less than 5 big boxes, it doesn't matter to me whether the heart rate is 90 or whether heart rate is 70. So I quickly look at this and look whether between 2 RR intervals, it is more than 3 big squares and it is less than 5 small squares. So if I have that, then why should I calculate whether it is 50 or 60, 70 or 80, doesn't matter. So I am finished with the heart rate. So I call this the rule of 3 to 5. So big boxes between 3 to 5, quickly you make this thing, the heart rate is normal. So let us go and see. Now I have got some quick calculators. So if I need a quick calculation, I look at it this way. I do not require very fine numbers. Like I don't need 173 heart rate. 173, between 173 and 170, it makes no difference to me. So I quickly look at it and see, is there one small square between two RR complexes? 300 beats. 2 150 beats, 300 beats, 4 75 beats, 5 60 beats. So beyond 60 it is bradycardia. You see, quickly you can go through that. So between rule of 3 and 5 you can quickly apply and then get through to what your heart rate is. Is it near 3 or 4 or 5, you can decide. So I call it the big box rule. This is my own coining of term. Now let us apply this very quickly here. Now you can see it is more than 3 here, right? You quickly made out it's more than 3. But when you come onto this side, you can see there are only 2 boxes. So here it is a normal heart rate. Suddenly you have a tachycardia, and here since it's only 2 boxes, it should be rate of 150. So your diagnosis of tachycardia is over. So I call it very quickly the big box rule. So apply it at bedside, you can quickly pick out all these small things. The next thing I ask is the P wave coming from the sinus node or elsewhere? For that, I ask myself a question. Which lead, the axis of the P wave is more towards the left side, that's approximately about 60 degrees. That is towards lead 2. So P wave always, most of the times is taller in lead 2 than lead 1. So quickly I go through it and look at lead 2 and lead 1. So lead 2 taller than lead 1 indicates that my P wave is coming from the normal sinus node. So if I have P wave taller in lead 2 than lead 1, and if my rate is between 3 to 5 boxes, I say normal sinus rhythm, that my diagnosis is over. Whether the P wave axis is 75 or whether it's 30, it doesn't matter to me. So it is. So I call this lead 2 taller than lead 1 rule to identify a normal P wave. I'll show you how to quickly pick out an abnormal one. Now, we are always interested in relationships. The next thing is I want to know whether after the atria is depolarized, it is depolarizing the ventricle normally. So I call it who is related to whom. So we are married, or we are divorced, or are we occasionally married or have girlfriends. So we look at it this way. We'll make it funny. Now quickly I look at it. I see that it is slightly more than lead 3 large squares. So my rate is okay. P wave in lead 2 slightly taller than lead 1. So normal sinus rhythm. PR interval is married to the QRS complex. So each of the P wave is married to the next QRS. So it's a very happy married life. So we call it the normal conduction. Now let us look at this relationship. Quickly, we see that the rate is more than 5 beats, so it's automatically a bradycardia. Whether it is 40 or 30, I can calculate later, but I know that this is bradycardia because the rate is less than 60. Now I look at this first beat, P wave is taller in lead 2 compared to lead 1. So this is a normal beat, and this is happily married. Now here I don't see a P wave, so there is no P wave, but a QRS is there, but this QRS has got a P wave after that. So actually here the reverse has happened. The ventricle is married to the atrium. It is the other way around. And the beauty of this is, this P wave is inverted in lead 2. So it becomes, actually lead 1 is taller than lead, so this means it is activating from below upwards. So very quickly, I have identified this is a junctional rhythm with a retrograde VA conduction. Suppose if I had this QRS the same as here, and a P wave which is normal upright here, then I would have said that's an isoelectric AV dissociation because the atria is also activated from the sinus node. So quickly I can make that out. Next, I call it PR, the less than 1 big box rule. So we all know more than 200 milliseconds, we call it as first degree AV block. Normally, when we see, I look at quickly and see if the PR interval is less than 1 big box. Now, whether it is 4 or 3, it doesn't matter to me. So I'm not interested. I know that PR interval is normal, and each of this is married to the next one. So I know that this is a normal conduction. Now let us look at this. Now look at this, and you can see, when you quickly see that the PR interval is slightly more than 1 small box, 1 big box. If it is more than 1 big box, quickly I have made a diagnosis of first degree AV block. And there is a 1:1 relationship. So I don't need to look at it and calculate very carefully. Now I know it is more than 200 milliseconds when I see this 1 big box. So I call it 1 big box rule, happily married to the next QRS. Each one of them. Now let us look at it. Now here you have 1 beat which is conducted with less than 1 big box. There is another one with no QRS after that. So this is like, you know, girlfriends, boyfriends. You are occasionally related, next day you may not be. So something similar to that. So here I know that each of this P wave and this P wave is conducted, the one is conducted, one is not conducted. I know quickly that this patient has got a AV block, and the heart rate, ventricular rate is more than 5 big boxes. The atrial rate is normal because it is between 3 to 5. So quickly I have made out that the sinus rate is normal, the ventricular rate is very slow, and I have got 2 P waves with 1 QRS, and I have made a diagnosis of high-grade AV block. So quickly you can go through this and you can identify it. Now let us look at this. This P wave is going by itself. The lower part is going by itself. The PP interval up is okay. So less than 3/5. And here you can see it's more than 5. So it is bradycardic. So each of this, it's completely unrelated or divorced from each other. So then I know if P wave is divorced from the QRS complex, you have a complete AV block. Now look at, once we finish this, P wave relationships, we have finished, we next look at the QRS complex. Now, I call it the little box rule. So normal QRS complex should be less than 3 small boxes. So it should be less than 120 milliseconds. But for me, it doesn't matter. I don't like to remember 120 milliseconds and all that. I look at 3 small boxes. So I look at it and see, I say, yes, it's less than 3 small boxes. So his Purkinje is working normally. So this is a normal conduction in the QRS complex. So I'm quite happy with that. And I also see that this P wave is taller than in lead 2, and it is more than 3 big squares. And I know 1:1 relationship is there. The QRS is narrow. So probably this is a normal conduction and looks quite okay. We'll go to other things later as we go on. Now suppose we have more than 3 little boxes. We get into what is known as a bundle branch block. Now when we have a bundle branch block, we have to identify where the traffic block is. So let us call it the traffic block. So I would like to know which, is it the right side or the left side? So to answer this, I ask myself, where are my rabbit ears? So if my rabbit ear is there in V1, that's on the right side, then I have a right bundle branch block. It's very simplistic. Here, let us quickly go through it. So P wave taller, this rate more than 3 big boxes, quickly the rate is normal. P wave taller in lead to normal sinus rhythm, PR interval normal, QRS broad, more than 3 big boxes, 3 small boxes, and next I ask myself which bundle is blocked. I look at it, the right side is the rabbit ears. You can see a rabbit ear, then I say it's right bundle branch block. Now let us look at it. I don't find a rabbit ear here. I find something which resembles possibly a rabbit ear here. So if it goes on to the left side, in V6, I call it the left bundle branch block. Now let us quickly go through it again. P wave taller, PR interval less than 1 big box. Then you have a QRS which is broad, and you have a rabbit ear on V6. So I call it the left bundle branch block. So PR interval is normal PR AV conduction. Nevertheless, below that, the conduction is abnormal. Now, the next thing I ask, where is the axis? So there are different ways of calculating axis. Many of you will go through the books and try to identify. But when I am on bedside, I quickly want to make a diagnosis and say, look, I want to quickly get the axis because I'm in a hurry. I have to see a lot of patients. So I look at 2 leads. Lead 1, AVF. Let us look at it. I look quickly, eyeball it. P taller in lead 2, 1 PR interval less than 1 big box, QRS narrow. Then I need to know the axis. I look at lead 1 and lead AVF. Both are pointing upward, normal axis. So I don't need to know whether it's 30 degrees, whether it's 50 degrees, whether it's 70 degrees. It's immaterial to me. All I need to know is quickly whether the axis is normal. Next, I'll say both are leaving each other, diversing, looking away from each other. They're angry with each other. Then I say, since they're leaving, it should be left axis. So I don't need to calculate sit and do the calculations. I'm quickly looking at, eyeballing this and looking at P taller in lead 2, yes. Then I have a PR interval, which is probably about 1 big box. QRS is interestingly more than, and you have a rabbit ear here, which is on the right side. So right bundle branch block is there. So you have a borderline PR interval, a right bundle branch. Then I quickly want to know the axis. So it gives me some idea of the fascicle block. So I look at it, they are leaving left axis. Very quickly you're finished. Next, look at this. Suppose we look at it and we see, okay, P again taller in lead 2, PR interval maybe about 1 big box, or slightly more than that. And you have a QRS, again slightly wider, right-sided rabbit ears. So right bundle branch block. PR interval, upper limit of normal, you could say. Then you look at the axis, lead 1 and lead 2 are looking at each other. That means they are reaching for each other, so it's right axis. So I quickly made a diagnosis of right axis. Right bundle branch block, first degree AV block, right bundle branch block, and right axis. Now,